Yes, sir, we are live now.
Thank you. Honorable dignitaries, esteemed faculty, and dear delegates, a very good evening to one and all. I, Dr. Rishikesh, feel privileged to welcome you all on behalf of the entire team at Emcure Pharmaceuticals. We at Emcure are proud to present No Thrombosis Live Inbox, our highly and acknowledged scientific program dedicated to exploring the multifaceted landscape of interventional cardiology. This program serves as a bridge between knowledge and practical application, aimed at equipping us with the tools needed to enhance the lives of those affected with the cardiac diseases. I take this opportunity to extend a warm welcome to our respected course director, Dr. C.B. Keshavamurthy sir. Sir is principal investigator for many landmark national and international trial. He has several national and international publications to his credit. Sir also participated as past president of CSI Mysore chapter. Thank you, sir, for your continued guidance and support for running this program successfully. Our distinguished moderators, Dr. Jabir Abdullah Kutti sir and Dr. Babu Ezumalai sir, are poised to share their knowledge, insights, and practical wisdom to empower us in the fight against the global health challenge of cardiac diseases. It is an honor for me to introduce our distinguished moderators for today. Dr. Jabir Abdullah Kutti sir is Senior Consultant Cardiologist and Director of Clinical Research in Cardiology at Lisi Hospital, Cochin. Member Secretary, Institutional Review Board, Lisi Hospital, Cochin. Vice President, Kerala Medical Association in 1986-1987. Secretary, CSI Kerala Chapter 2008 to 2012. National Executive Committee member of CSI. Sir is Honorary Secretary for the Society for Heart Failure and Transplantation. Organizing Secretary of Annual Conference of Society for Cardiac Imaging and Physiology 2020. Secretary Cardiovascular Research Society, faculty at various national and international conferences. Sir has various publications and textbook chapters to his credit. Sir is also editorial board member of Indian Heart Journal. Warm welcome to you, sir. Let me have privilege to introduce our second moderator, Dr. Babu Ezumalai, sir. Sir is senior interventional cardiologist at Apollo Hospitals, Vanagaram, Chennai. Sir is honorary professor at Tamil Nadu, Dr. MGR Medical University. Sir is recipient of Best Young Scientist Award at TCTAP 2017 Seoul, EAPCI Young National Ambassador for India in 2017 to 19, National Ambassador of India for European Association of Cardiovascular Imaging, Club 35 in 2013 and 14. Sir is proctor for leadless pacemaker implantation in India, invited faculty in many national and international conferences. Sir has presented many abstracts and cases in national and international conferences and won many awards. Sir has publications in peer-reviewed national and international journals. His area of interest are coronary and structural heart interventions and heart failure. Thank you, sir, for joining today's program. It is a privilege for me to introduce our speakers for today. Uh, Dr. Biswaranjan Jaina, sir, is Senior Consultant Interventional Cardiology at Dr. Jaina's Cardio Diabetes Center and Aswini Hospital, Cuttack. The topic which he is presenting today is non-left main bifurcation. Thank you, sir, for accepting our invitation to present the case. Let me have honor to introduce our second speaker, Dr. Partho Chaudhary, sir. Sir is Chief Consultant Cardiologist at Mediterranean Hospital, Jamshedpur. And the case which he will be presenting today is rotablation in a case of wire-induced right coronary artery dissection. And finally, I would like to extend a special welcome to all the delegates who have joined today's program. It is an honor to have such an esteemed audience and renowned experts among us. Let me brief you all on the meeting agenda for today. We'll kickstart the program with the opening remarks and context setting from our respected course director, Dr. C.B. Keshavamurthy sir. Then it will be followed by case presentation by Dr. Biswaranjan Jaina sir, and it will be followed by a discussion among the faculty members. After that, we'll have a second case presentation by Dr. Partho Chaudhary sir, and followed by a discussion of the faculty members. Post the discussion of all the cases, we'll have concluding remarks by our respected course director, Dr. Keshavamurthy sir. I request audience to put their questions in the comment box. After case presentations, we'll take up those questions for discussion. So without further ado, let's embark on this educational voyage together as we endeavor to enhance our understanding of interventional cardiology. I request our esteemed course director, Dr. C.B. Keshavamurthy sir, to share his opening remarks on today's topic. Over to you, sir.
Thank you, Dr. Rishikesh, and it is my great privilege and honor to welcome you all to this excellent academic journey. it's a very distinguished kind of forum where interventional cardiologists get together and discuss purely case-based discussions, which is a very attractive kind of platform to present, not only present your cases, but also have good discussion. And the end of it, we'll all learn something out of these presentations to each other. And thank you all delegates for joining in and spending your time. I'm sure you'll be a bit wiser when we leave this forum later in the day. Without much ado, we'll start off with the presentations. I have the great privilege of co-moderating this session with Dr. Jabir Abdullah Kuti, who is my great friend, and Dr. Babu Elumalai, whom I'm meeting for the first time, and I'm sure they are great people in their own fields. So we'll start off with the first case presentation. The first speaker is Dr. Biswaranjan Jena, who is consultant and interventional cardiologist at Ashwini Hospital, Kotak. He is presenting a case of non-left main bifurcation. In this forum, we have tried to kind of present cases theme-wise so that there will be some continuity of thought, and the comments and the learning will also be more organized. But at some times it would be difficult to find a very similar type of cases to present. So we'll go along with the theme. The first case goes along with the theme, like non-left main bifurcations, which we are trying to learn how best to treat non-left main bifurcations. And Dr. Biswaranjan Jena will tell us how to do it today. Dr. Biswaranjan, please.
Yes, sir. Thank you. And thank you, my thank you to esteemed faculties. And it's an honor to present the case among best in the field people from India. And thank you, Emcure, for giving me this opportunity. So, as Kesamurthy sir told, that this will be a case of non-left main bifurcation. So, just a second, I will share my slides. Yeah, so coming to the case, basically, this is a bifurcation stenting done in a ACS setting. So coming to the clinical profile of the patient, he is a 50-year-old male, he is a diabetic, he is a smoker. He had ongoing on and off angina for last 1 day. There was STT changes in the chest leads in ECG. TROP-T was positive, and echo was showing LV ejection fraction of 40 to 45% with RWMA in LED territory. So coming straight to the angiography, basically as you can see over here, this is the left system means caudal view. As you can see over here from the caudal view, there is little bit of short like means short LMCA, and the angle between the LED LCX is good, and LCX osteum looks non-diseased. And if you can see over here, we can definitely know that from here that there is the issue is here that the LED and most probably the diagonal is having a lesion. So different view has taken, as you can see over here, it's a cranial view. And we can see that the lesion is almost at the just near to the LED osteum, and this diagonal is a high diagonal rising almost near to the osteum itself. So this is the angio view, and patient is in ACS setting. Patient has some ongoing angina, and you can see over here there is some means fluoroscopically there is some hypokinesia in the LED territory itself. So what are the challenges? Challenges is ACS. There is ongoing angina. There is some form of LV dysfunction, 40% around ejection fraction. So we have to mind the time and the contrast. And definitely there is a bifurcation lesion, and bifurcation lesion in long left main, but it is very close to the left main, and left main is it's a relatively short left main, and the bifurcation lesion is in means high diagonal and LED, and the Medina classification can be 0, 1, 1. So means my thinking was whether means as the angiography we can know that it will be difficult for a one stent strategy because osteum, and the osteum proximal part of the diagonal is a tight lesion. And so basically, we have to go for a bifurcation stenting with two stent strategies straight away. And thing is that whether to stent it from LMCA to LAD, the crossover stenting, because it's almost up to the osteum, and what should be the means technique, whether it should be coulot versus cross. So this is the thinking process in my mind. But the plan was to go for two stem strategy, and it will be a cross technique to means because it will be little easier than the coulot. And the thing is that basically I want to stent it from the LAD osteum, because LCX there is a angle is good, and there is a means osteum little bit of free of disease in the LAD. So plan was to stent from osteum, two stent strategy, and I will go with the cross technique. It will be mini or nano cross technique. So to start with, we have to wear both the vessels. It was done with the BMW wear. As you can see over here, both the vessels has been wear. Then the main branch was pre-dilated with 2.5 into 12 millimeter of NC balloon. Similarly, the side branch also means pre-dilated with 2.5 into 12 millimeter of NC balloon. But as you can see over here, post balloon, there is still a means LED is little bit of open, but the diagonal is still means it recoiled. Basically, it's a fibrotic lesion. So after multiple dilation in the side branch, I have decided that okay, we'll go for the stenting. So side branch stent was like 2.5 into 24 millimeter of dog-eluting stent, and main branch was 2.75 into 34 millimeter of dog-eluting stent. As you can see over here, to this spot, or means there is no exactly means we don't have a IVUS. Angiographically, it is very difficult to locate the means because of this foreshortening and little bit of angle is very narrow. It was very difficult to position the stent or to know where to put it. But thing is that I have taken this stent which to guide me, and as you can see over here, uh, and both the stents were taken simultaneously. One stent is kept at the left main, and the other means the side branch was dilated first, as you can see over here. So basically, stent V sometimes can help you when the angiography is not giving you the exact picture. So this is the thing, and after that, once again, I have dilated it once more, because the means now the side branch is looking little more dilated. Then, of course, in the cross technique, we have to dilate the main branch vessel now. Before that, we have to remove the side branch because it can be jailed over there because we are crossing the stent. And after this, stent positioning was done in the main vessel. And as you can see over here, this is ostial LED ostial stenting, and this is the dilatation of the balloon. So post stent, it looks okay, and patient angina is little bit of subsiding, flow is good. So the next thing is to go ahead, and as you can see over here, we have confirmed it about the cross basically with the stent width. And as you can see over here, the osteum is covered, and there is nano cross, means only a few struts has been crushed with the main vessel itself. Then as the process goes, we have to rewire the side branch, and after this rewiring, post dilation of the main branch with 3 into 12 millimeter of NC balloon, and side branch with 2.5 into 12 millimeter of NC balloon. So this is basically, so this is a, then I have taken a means trach balloon, that is 2.25 single marker. So side branch dilation, then main branch dilation, and after that, this is the stent V's, and then this is the kissing, and after that, final kissing was done with 2.5 into 12 millimeter of NC volume in both at 10 atmospheric pressure. So now it looks better, and as you can see over here, the flow is good, and this is the final result. This is the cranial, and this is the caudal view. And this is how it looks in stent views. And procedure completed in fluoro time of 22 minutes. And thank you. Thanks a lot.
Thank you, Dr. Biswaranjan, for that excellent and short and sweet presentation of a non-left main bifurcation. I now invite my co-moderators. Dr. Jabir has joined. Dr. Babu Edamalai, please go ahead with your comments and discussion about the case.
Yeah, so that was a nice demonstration of crush technique. Our presenter had some difficulties. We can understand that because it was a very early rising bifurcation close to left main. So we can see that, we can understand, even presume that there's going to be problem in pot and all those things after once we are going to stand. So he has taken from ostium of LED. I think imaging also would have been helpful, but again, it is an ACS situation. So there, the early we get out of the case, then it's good. I could see that even the positioning of the stent was difficult, so he had to use that stent waist to see that where he has positioned. So those points he has taken care. And this regarding this post dilatation, I think you had taken main vessel stent, that LED stent is 2.75. And then after that, when you did final kissing for when the main was LED was 2.75 and diagonal was 2.5. Now for kissing balloon dilatation for both the vessels, you have taken 2.5 and you have done that, right?
Yeah.
Sorry, you said. I think because main vessel is this thing, and then
it will come around 3.3. The main vessel will come around 3.3. Because there is no space particularly, means that to do the pot and everything also, there is no
very
much
difficult.
end left. So that's why to be in safer side in ACS, I think I have taken a smaller size balloon and means around 12 NC. I have dilated it around 12 or 14 atmospheric pressure, both those things.
So, and one more thing was this, whether you would have done when opted for provisional stunting, like you would have gone for a single vessel because ACS situation. So, or because you had pre-planned for B stunting, I think, crush technique, two stunt technique. But what about like going for a provisional stunting, put some left LED stunt, and then think that whether to go for a diagonal and then do that because it's the ACS situation.
Yeah, means at that time, but the vessel size, if you see, almost these are similar type of vessels, like twin LED, and it is almost rising from the proximal part, and diagonal is a good size vessel. So I thought that, and it is disease actually. The means it's the disease part, the osteoproximal part of diagonal is significant. So that if I thought that okay, if I am not putting a stand over there, I am going for a single stage. Once I lost that vessel, no, I have no much space to maneuver after that anything. To rescue, it will be very difficult. So that's why I thought that, okay, still ACS, but I have to go for a double strength strategy.
Yeah. So I also would have done the same thing. So that's any very good strategy you have followed. As you said that suppose this vessel, side vessel closes here to see the anatomy only was very difficult. So recrossing would have been difficult. So going with the first sideband straighting was a good strategy. And this recrossing, rewiring, because of the crush technique, so where you do that for the benefit of the listeners, audience. So how do you do this in a crush stent, where you do like distal part, proximal part, or mid part, or like when you're rewiring?
No, rewiring, basically, if it is a distal stud, then it will be better. But thing is that means means as the bifurcation law goes, if we can go means at the means to form the new carina, okay, so that we can go for the discharge. But sometimes it is very difficult to know whether means we are going distally or we are going that proximal stud. Thing is that in ACS setup, we want to save the patient at that time, and at last, I think with the stand bridge, we can know. I have seen that okay, vessels are well opposed, and the cross is not much also. Not much metal burden at the ostium itself. So accepted the result like that.
Yeah,
Or a
and
precise, okay, go ahead.
please.
The
Yeah,
only thing
please welcome, sir.
you know about
Welcome,
the
sir. We
precise
were waiting for
closure,
you. Yeah, you can
a
tell your comments.
precise crossing, a precise because any crush technique needs a non-distal crossing, and to be precise about it, we really need an imaging. Without that, our visual assessment of the stud may not be that correct. But all said and done, we all have been doing this for a long time, and once we cross the strut with a difficulty, and it is extremely unlikely that we'll pull it back and do the rewiring unless our balloon is not crossing. That is in the practical scenario. I think it is almost like that. If our balloon is easily crossing, especially in ACS situation, difficult stenting, we'll complete the procedure and get out as early as possible. But if the imaging shows this thing, we may pull out the wire and rewire again. What do you think, Keshavamurthy? Dr. Keshav?
Yeah, absolutely. The whole idea of starting this non-left main bifurcation discussion was to see how the practice has changed over the past few years. For the past 2 to 3 years, I have not done a non-left main bifurcation with 2 stents. We completely changed over to drug-eluting balloon, and that is the strategy. Like in the European bifurcation club, you always start with a provisional strategy, especially in complex bifurcations like this, where you have a very proximal bifurcation and there is no area for a pot or no sufficient room to do a proper culot or a double crush technique, which of course complicates matters. So the simplest thing, what I would do, even in this case, irrespective of the vessel size, is direct the side branch, preserve the side branch, do everything you want to do on the side branch, put a drug-eluting balloon, then put a single stent across the diagonal from the proximal LAD and finish off with 1 stent strategy. We all know that on follow-up, when you put stents which are like 2 millimeters, 2.25 or 2.5, most of the events, about 60% of the events are occurring at the side branch ostium. So when this patient comes back with a side branch event, what do you do? That is what we have to think at the outset itself. And that is my strategy. That is my opinion. And like Dr. Jabir said, if you have imaging, cross and do the optimization, the accurate angioplasty, or what they call precision angioplasty, now you do all that. But I would still go with a single stent strategy for any non-left main bifurcation. Even in the left main, off late, if the circumflex is small, non-dominant vessel, we are still doing a single stent, irrespective of the size of the circumflex, irrespective of the lesion in the circumflex. I'm committed to a single stent strategy. That is my personal opinion.
Yes, sir. Given the choice now, I should have gone what you have told, that side branch, I will do the drug-eluting balloon and I put a single stent. That time, actually, I didn't know what is I am going to find in the angiography. It's a ACS situation, and that particular size of drug-eluting balloon was little bit, I think that was not available at that time. So to save the situation, we have to go like that. Otherwise, what you told, sir, it's best to go for a, if at all we want, something to do with the side branch, then drug-eluting balloon is a good choice also nowadays to go for a single stent strategy. Yes, sir.
Drug-eluting balloon is coming up as a big change, or it's the acceptance of drug-eluting balloon is coming up, especially for the side branch in bifurcation lesions. Especially if in the ACS situation, so we are worried about the slow flow, stent thrombosis. So when we are worried about all these things, a side branch drug-eluting balloon is a good choice. And now we are all gaining experience with drug-eluting balloons because we were afraid of these dissections. Now we are little more courageous to leave certain dissections, though they look dirty and horrifying things angiographically.
Yeah. There are a few things you have to, in the last TCT, there were a lot of presentations about drug-eluting balloon and subsequently the approval of drug-eluting balloon in the US. The observations were like, you should be prepared to accept what looks like a suboptimal result. We as interventional cardiologists, we are always looking at a perfect, angiographically perfect looking result, but that is not obtainable with a balloon. Even if you do bed preparation with a cutting balloon or a scoring and then put a drug-eluting balloon, still the result will look ugly. But if there is STIMI-3 flow, and if you have a FFR on the side branch, many of the times in the circumflex, if I am doing a left main bifurcation, I keep the FFR wire in the circumflex. And if the RFR is more than 93, if it is normal, I just generally accept that result. Small dissections are okay. If there is STIMI-3 flow, it is a large vessel, it's not going to affect the long-term outcome. From the Italian group, we have a lot of evidence for that. So be prepared to accept that little bit of ugliness or haziness or dissections and look at the long-term results. They are much, much different from putting 2 stents.
And not only that, as you suggested, now we have an option. If the patient comes back with a problem, our options are much better than stent restenosis at the bifurcation side branch.
Yeah. As you see more and more bifurcations which are coming back for a reintervention, especially those stents which have been done at another center. I am not critical of them, but whatever they would have done their best. It's so difficult to cross them, especially if you don't have the notes, what they have done, what kind of strategy they have used, whether they have used imaging. It becomes extremely difficult to cross into the side branch and salvage the side branch. That is what I found in the last few cases. If there is a restenosis, then patient is definitely headed for a surgery.
So one
Yeah.
question, have you, are you doing, sir, this drug-eluting balloon like bifurcation means without any stent? Is there any experience like just going with two balloons and just dilating it? Means bifurcation lesion, non-left main, and
Yeah.
both are drug-eluting balloon and will be means doing it as a PTC strategy.
Yeah,
So,
we are not doing that as a default strategy. Of course, the larger vessels like the main vessel in the LAD circumflex, we have to stent them. But recently we had a case where this patient had a massive GI bleed about 3 days back, and he had clips in his duodenum to stop that bleeding, and some varices also which were clipped. And he had an anterior MI and a LAD diagonal bifurcation. So in this situation, you want to avoid the complexity of DAPT and
DAP.
whatever it is. So we put two drug-eluting balloons in this patient and did a kissing with two drug-eluting balloons. So this patient is doing well at 30 days follow-up. So we do not really have evidence to say that in large proximal vessels, as interventional cardiologists, we are a little hesitant to leave a proximal LAD large vessel lesion with just a drug-eluting balloon with a dissection. In an ACS, especially if there is a thrombus, the risk of abrupt closure is there. So, but you should consider in high bleeding risk situations where a patient has to immediately go for some kind of emergency surgery, and you are doing a balloon. Instead of doing a plain balloon, you can do a drug-eluting balloon and give him good sustained results. He may not require another procedure at all.
Yeah.
Yeah. Any other comments about this case? There was another peculiar situation I would like to share just for the interest. This patient was a young 45-year-old gentleman with diffuse triple vessel disease, and because of the long lesions in the LAD, he was declined for CABG because surgeons would not, if they are not putting a lima to LAD, then there is no point in sending the patient for CABG. So what we did in this patient is we did a drug-eluting balloon for the entire length of the LAD and one of the diagonals, and left him without any stent, so that in future, if he comes back with a restenosis or whatever, and he requires a CABG, the vessel will still be available if surgeon can do endarterectomy, or you know that if you have implanted a drug-eluting stent and patient comes for surgery, it becomes very difficult for the surgeon to take out the stent, or he doesn't have enough place to put a graft. So fortunately, in this patient, he came back at about 1.5 years of time with some mild kind of angina and a positive treadmill. We put him on the treadmill, and LAD was completely patent. It was looking almost normal with no lesion. Then his CABG itself got avoided. He is on optimal medical management. So this is the kind of things that DEB has opened up. Really, I don't know, it will come into the guidelines or anything. It's an anecdotal case, but you should seriously consider it in young patients, especially.
Dr. Kashyap, I have also made it a point nowadays that I will not put a stent into the area of the surgeons. That is the domain of surgeon, because we don't have a cure for atherosclerosis. We are sure that in the trajectory, these patients will come back at some particular point of time. And at that time, the surgeon should be able to put a graft. I was similarly, I was telling my surgeon that you don't have to go for endarterectomy. I'll do a drug-coated balloon. Let's see whether a positive remodeling occurs. Then when he comes back, you can put in a graft rather than doing endarterectomy.
Absolutely, absolutely. The LAD tends to grow if you treat the critical lesions and let it allow the flow. LAD had grown. By the time he came next time, you could not recognize that it was the same LAD which was so diffusely diseased and so thin in caliber. At this time, it looked pretty good, like a normal LAD. So you should definitely consider, especially in the younger group of patients, rather than creating a straight metal jacket, putting a lot of stents. We used to do that earlier, like elephant trunk. We used to put stents from ostium of LAD to the distal portion. Now we have stopped doing that.
We are gaining wisdom from our own mistakes.
Yeah, obviously, a lot of it.
Right.
Thank you. Thank you for the wonderful comments and from my co-moderators and from the presenter, Dr. Biswaranjan. Thank you very much again for that wonderful case and great learning points that we gathered from that. And I'm sure you'll come back with more such cases to this forum.
Thank you.
I now
Thank you.
invite Dr. Partho P. Chowdhury, Chief Consultant Cardiologist at Medtrina Hospital, Jamshedpur, to present his case, which seems to be equally interesting, a dissected case with a rota.
So just a minute.
Your screen is not visible yet.
Just just give me just 2 minutes.
Okay, okay.
Am I visible now?
Yeah, we can see your screen, but presentations we are not
Then
able
yes.
to. Okay.
Can you see my slides now?
It's just
It's
opening.
opening. It's opening. And so we are not able to see you. Your camera is.
Are you able to see everything? It's fine. Can you see my slides?
No, not yet. We can see your folder and see the rota dissection file, but
Slides you can see, but here it is.
it's not opening yet.
सर आपका अभी केस हुआ है क्या ओपन हुआ है प्रेजेंटेशन में
हाँ केस तो खुल रहा है
तो आप अभी हाँ अभी चालू हुआ
चालू
Now,
है
Yes. Now
let's
we are
start.
able to.
So actually everything okay? You can see me as well as you can hear me?
We
Sir,
can't
we
see you, sir.
Leave it. Can you see my slides?
Yes,
yeah,
sir.
we can see your slides. Please go ahead.
Sir, let's start. Sir, actually mine is a simple case. It is about how a simple case can be made complicated. So a 70-year male who is hypertensive, diabetic, obese, came with CCS class 3 for angina, TMT positive. CAG showed TVD. He is on maximum antiplatelets beta blocker and is on injectable insulin. And now we can see the angio. We'll start with RCA. RCA, it looks a simple lesion. It is like angiographically, it is mild to moderate calcification, about 80 to 90% lesion. This is L6. L6 is, look, there is a discrete lesion proximally. And this is small OM, small caliber OM. Distal L6 is also small. Now, this is LAD. As you can see, there is a proximal, very significant lesion, and it is also mild to moderate calcification. After like discussion with patient, he opted for multi-vessel PCI. So we started this with LAD. It was easily dilated with a 2.7512 balloon, and we put a 338 Zymes, and we did a
Dr. Partha, I don't know whether others are able to see the video. I'm not able to see the video.
sir,
Video is running.
Videos are playing. I don't know.
Okay.
Video is running, sir.
Okay,
Yeah.
I'm not seeing. Okay, I'll exit and come back again.
Yeah, rejoin. Maybe rejoin.
You can go ahead.
Okay.
Yeah.
So it was uh, dilated with an OP and NC balloon.
Okay.
And this is LAD. As you can see, there is a proximal, very significant lesion, and it is also mild to moderate calcification. So we started this with LAD. It was easily dilated with a 2.7512 balloon, and we put a 338 Zymes, and we did a
Okay.
And this is the final result for LED, and it looks quite good. Now coming to LCX. LCX also, it was not a difficult one. It was pre-dilated with a 2.9 mm balloon, followed by a 2.5 into 12 mm balloon, and it was stented with a 2.75 38 Zynes. There was a bit difficulty in crossing the stent. With the help of guide liner, it was crossed, and it was like this is the result. Now let's come to RCA. Now we start the RCA, and the thing was, even with the help of a guide liner, you can see even 1.5 into 15 mm balloon, we were not able to cross that bend. Now the thing is, after repeated trying, everything came out, and the patient developed chest pain, and there was a. It is clear there was a dissection in the RCA, and as you know, like whenever dissection, we shouldn't give forceful injection; it extend the dissection. So we get to give a very slow injection. These are the multiple views where you can see there's a proximal dissection. And since this is a spiral dissection, now the thing is we were not able to cross the wire. And if the patient developed bradycardia, chest pain with like many efforts, lastly we were able to cross the lesion with the help of a field FC wire. We put a temporary. Now the thing is, we know we are not able to cross it with a balloon, and we all know the second thing what we can do, we do a rota. But the thing is, rota ablation is a contraindicated in case of dissection. So we again tried it with a balloon. Thinking that maybe we could be able to cross it again with a balloon because the lesion was looking very simple. But unfortunately, we didn't cross it again with a 1.5 or 2 mm balloon. Now, lastly, we decided that last resort, what we have it is to do a rotablation. So, with the help of microcatheter, actually, in fact, if a microcatheter went up to mid part of the RCA, and we changed the wire with a rota wire. Manually, we crossed the lesion with the rota wire. However, doing rota in this case was not difficult with hardly 2 or 3 runs. The rota was easily crossing across the mid part. Now what we did, we changed the rota wire with a fielder FC wire. You can see dissection extended proximally. Fortunately, it didn't extended distally. And next is what we did. We took again 2.9 SC balloon. This time it crossed proximally as well as distally. Though again it was a with bit effort. In fact, we use a guide liner to cross the balloon distally. Again, we took a 2.53 mm balloon to, with the help of guide liner, we dilated well the mid and distal part. Now, with the help of a guide liner, we put 3.5, 3 into 38 distal stent, and proximally, it was about 3.5. So stent was like overlapped. And finally, we covered the ostium also, and we did a good post dilatation with a 3.5. And just I'll show you the final result. So this is the final result that we have after putting to a stent. There was good TIMI3 flow, and stent were very well opposed. So what conclusion I can draw is, in case of calcification, as we all know, angiography is the least sensitive, and obviously OCT IVUS they should be handy and they are very useful in such case. And secondly, though rotablation is contraindicated in dissection, this is the only option for us to bail out in such cases. Thank you.
Thank you, Dr. Partho, for that excellent case presentation and very nicely handled after the dissection and patient became kind of acutely ill. Very nicely stabilized and handled at stepwise. You have done a very good result at the end also. I now invite my co-moderators to make their comments and then we can have a discussion. Dr. Babu, Dr. Jabir joined back.
Oh, it's I think I congratulate him for his his presence of mind, because I'm sure he's a single operator in you are in Jharkhand, isn't it?
Yes, sir. I'm Jamshedpur. Like it's a small cath lab. Like I
I
do
know you are in the
30,
small
40
cath lab,
cases.
single operator. You don't have the luxury. We have a lot of operators around.
Sir, I don't have cabbage and all these things.
Right, absolutely. So you have the presence of mind. Though initially when we all started doing rotablation, we were all afraid of doing rotablation, or rather dissection was a contraindication. We all, if we have planned for a rotablation, we all do upfront rotablation, because if we cause some dissection, then it will be not possible to do rotablation. Even now, I'm afraid of putting rota or orbital into a dissected area. I may not do it, but you did it, and that was the only option for it to left. Initially, what the only change I would have done is initially I would have gone ahead with an Amplatz catheter. I don't know whether you used Amplatz. I thought it was only an RCA catheter.
So RCA was looking very simple. So like I
Right.
don't think, because I took help of a guideliner also.
I saw that
I
guideline
don't
because
think
right.
Amplatzer would have been of much help.
I think an Amplatz ephemeral route would have given extra support. That's the only change I could have thought of. Otherwise, you did the best possible, and you got the best result. That is the proof of the pudding. You got an excellent result. The vessel was flowing and the patient was saved. That's all. I think a wonderful work you did.
Dr. Babu,
Yeah.
would you like to make some comments?
Yeah, so that was like a multi-vessel stenting, and as a speaker said, that he has been doing this in a small cath lab, which less of manpower around. So as Dr. Javed said, in that case, in such a situation where they don't have much of manpower or limited resources, so better to start the case with good support. Like definitely, while he was doing L6, only you would have learned that it was difficult to go. In fact. So L6, I have a doubt first whether OPN was used for LAD. For L6 also, OPN was used for L6 also?
No, sir, OPN was used for LAD post-dilatation.
LAD post-dilatation. So, no, you had some difficulty in stenting because it was all calcified and it was taking a nice bent curve there. It was tortuous, and L6 is always problematic, and especially you're going to put a long stent there. So definitely you would have faced that. Then RC also, you could have taken, as Dr. Jamil said, femoral route. In fact, even a long sheath or Ambrose catheter. I would have gone for Ambrose catheter.
Sir, but
Immediately you should change.
Amplatzer wouldn't have been much use, sir. Actually, the thing is now, because even when I was crossing the rota wire, I thought it would cross very easily. In fact, that microcatheter was not going beyond the mid part. It means there is something problematic. Even when I was exchanging wire, over the field IFC, microcatheter went up to that proximal part, then stopped. So on that halfway microcatheter, I changed to floppy rota wire and I took it manually. It means there is something in mid part. There is something, a spikel of calcification, or there is a something problematic is there, because like even microcatheter was not going beyond that. That is
Here
the thing.
here the problem seems to be angiographically we are not seeing
See,
calcium.
that
So
is what is the
excellent.
angiographically, sir, in presence of calcification, it is very underestimating. It
Okay,
looks very
40%.
simple. It doesn't look, it is going to be so much heavily calcified.
Right,
It
it's
is
a
not
40.
like, looks like a heavy calcification. It looks like a simple lesion, because before that I did many such cases. So it doesn't look.
40% of the calcium will not be detected on angiography.
Yes,
And
sir.
this, I think at the bend, this may be an eccentric calcific
Yes, that is what I'm telling. Because even microcatheter was not crossing that part. That is what I'm telling, sir.
Okay, a rota, you have to rota, that's the rota drive. Rota drive may be a better way to wire directly. The
Sir,
Viper wire is an excellent wire.
Sir, rotaviper actually created the dissection. When I took rotavire directly, it created the dissection.
Right.
Actually, I thought it's a very simple lesion. Rotavire will cross easily. I didn't use microcatheter. I manually tried to cross it with rotavire because I've used many a times. But it created the dissection. That rotavire created the dissection.
Was it a rota drive or a simple rota floppy wire?
Sir, second time when I decided to do rota, no, because I
Took
took a rota wire and I tried to cross it. So that when I, without microcatheter, I was trying to manually, but it looks simple. It created the dissection.
No. There are two rota wires. One is the rota drive.
Floppy,
and
floppy,
the new wire.
floppy,
With a
floppy.
newer,
Rota,
Rota
there is a
floppy.
new rota drive wire that is a better
Okay,
wire.
okay,
Yeah.
sir. Okay, sir. I don't have that. Rota simple, rota floppy wire.
That rota drive is a better wire to cross with.
Okay, sir.
Many a times in a difficult situation, usually our microcatheter will not cross. That is a rule.
yeah.
You use did you use an Oxford microcatheter or a New York microcatheter?
Sir, it was not
Oxford.
very Oxford. It was not a very Oxford, but it was Oxford.
Difficult situations, you cannot rely on Oxford materials, especially Oxford microcatheters. It won't take such eccentric calcium and that curvature. It was a difficult curve.
Excellent discussion. And it's always a dilemma for the interventional cardiologist that how far we should go. And sometimes this calcium on angiography alone is so misleading. You think you can get away with a NC balloon or some plaque modification and try to put a stent, but you end up with a situation like this, especially when there's a bend, tortuosity, unanticipated calcified plaque, which is projecting into the lumen, which prevents progress of any equipment down the vessel. So these are all great learning points, especially the great experience of Dr. Jabir helped us here to learn quite a few points about rotablation in a angulated lesion in the proximal RCA. Thank you again, Dr. Partho.
So should I ask one question, sir? Like on your experience?
Yeah,
Sir,
yeah.
like what is the basis of selection of cases for orbital atherectomy or rotational atherectomy or IVL? Like how do you select it that which cases you do with rota or orbital or IVL? Though I know it's given in book, but I just want to learn your experiences. Like how do you select I should do IVL, I should do rota or I should do orbital? Like
Dr.
which case?
Jabir, I think you will answer.
If it is a balloon crossable lesion, you can think of IVL. If you do an imaging and see only a deep calcium, no superficial calcium, it is for IVL if it is balloon crossable. But if there is superficial calcium, that means calcium close to the lumen as well as the deep calcium, the calcium between the lumen, and there should be an area of fibrous tissue between the lumen and the calcium in the deeper part. Then that is the deep calcium that the rota is unlikely to touch that calcium. So in that situation where you have a deep calcium plus superficial calcium, you may have to go for a mixed strategy, an ablative plus a calcium cracking, so something like a balloon strategy, most likely an IVL. If a balloon is not crossing, then IVL is out of question. IVL may come back once we do the ballooning, but then whether it is orbital versus rota. If it's a very tight lesion, ankulated lesion, I may go for a rota. If it is a big vessel, if it is a calcified nodule, and if the patient can't afford or the operator cannot afford a slow flow, I'll go for an orbital. That is what simple strategy I use. If it is a single vessel, surviving vessel, chance of slow flow is high, severe LV systolic dysfunction, and we expect a slow flow, and the slow flow can be detrimental. I will always offer orbital where the slow flow chance is very less. And the second thing is, if it's a big vessel, eccentric calcium and a calcific nodule, I'll go for orbital atherectomy. Very tight lesion, difficulty cross even with the wire, and also very ankulated lesion. Very small size vessel, I may go for a rotablation.
As an isolated deep calcification, does it affect your stenting?
What? I didn't get it.
If you have isolated deep calcification, so does it affect stent expansion?
Definitely.
Not allow this. Another point is the proximal tortuosity, where orbital atherectomy seems to have some advantage because it goes both ways. Once you take it across the lesion, you can rota backwards, which seems to be an additional
Yes.
advantage.
Patient osteal lesion.
And one additional situation is aorto-osteal lesions where you can go with the glide assist into the lesion and then we can do the retrograde planting.
Yes.
Yeah.
And also you can use like orbital for multi-vessels. Like suppose you have one LAD and left main also lesion is there and RCA, otherwise size one crown will be enough for all this thing. But in rota you may have to choose different bus, so it may be cost effective also. And as Dr. Javed said, I have used maybe in many of conditions where left main LAD lesion is there or single post AVG, single vessel surveying, all those conditions orbital because the particle generated is very small compared to rota ablation. So slow flow chances are very less. So we can confidently use it.
The speed is also very slow, so there is less chance of
No
like
reflow.
precipitation.
Yeah.
Yeah.
But you need a lot of patience if it is a multi-vessel.
No,
Multi-vessel orbit.
takes
Orbital.
time. Yeah,
Our
takes-
center is like so we have no like such luxury of using so many devices. What we use is only rotablation. That is the thing that we have to use it twice or thrice. That's
After doing all these things, what I feel is that 80% of the cases, a rotablation is sufficient.
yeah, that is what, sir. We are experienced with only rotablation.
Rota
That's
is sufficient.
rotablation.
Yeah, after all the discussion, academic discussion in our real life practice, cost becomes an important issue. With the addition of one imaging modality, one additional modality of treatment, like even a simple thing like a rota or an orbital, it adds almost 2 lakhs to the cost of the
Yes.
patient. In many situations, patients suddenly, even kind of reasonably affording patients become hesitant when you explain an additional either imaging modality because they're not sure how it will help them. You know, as an interventional cardiologist for left main, for stent optimization, for precision angioplasty, you require all these support, but making the patient understand this becomes extremely difficult in real world situations. And
We
that
Sir,
is
we
imaging
started doing orbital only some 3 or 4 months ago. We could do only 12 orbitals so far.
yeah.
About Babu, how is it? The orbital number? It is 2.5 lakh for us. And the orbital is only 1.5 lakh.
Yeah,
Yeah.
orbital is in the sense that compared to IVL, orbital is cheaper. Orbital IVL is very, very costlier. But rota, yeah, we have
cheapest is
rota is, I mean, cheapest will be rota. So if you're using straightforward cases, you can always use that. Rota, if you're experienced, you can use it. But there are many situations where you cannot use rota, but you can use orbital. It will be safer also. Extreme when EF is very low, as Sir said, EF is low, single vessel, and all those conditions, I think orbital is safer.
And most of these cases, you have to add imaging. So obviously,
Yeah, so complex cases like multi-vessel disease, what this last case was present as, all those things, I think you are supposed to have, it's class 1A indication. So you should have an imaging modality.
So this cost escalation becomes an important issue. Yeah. Thank you all for the wonderful comments. I request Dr. Rishikesh to see if there are any comments in the chat box, any questions that need to be answered.
Let me check, sir.
Nothing. No.
So far there are no comments, sir.
Thank you. So if there are no further comments, I thank my co-moderators, Dr. Jabir Abdullah Kuti. It was a real bonus to have you. When I saw your name, I thought it's a forum. And suddenly we had Jabir here to share his vast experience about various modalities of treatment. I thank Dr. Babu and really thank the presenters for bringing these wonderful cases to this forum. This is a continued journey of learning with the only objective of exchanging ideas, especially the younger cardiologists who want to showcase their talents and cases can come up with more and more interesting presentations. And thanks to Emcure for this wonderful opportunity to be here and learn a lot of new points. Thank you all.
Thank you.
So,
Thank you, sir.
We are nearly at the finish line, but before we conclude, let's express our gratitude to all those who made this scientific program possible. I would like to express my sincere gratitude to our esteemed course director, Dr. Keshav Murthy sir, and our distinguished moderators, Dr. Jabir Abdullah Kutti sir and Dr. Babu Ezumalai sir, for sharing their knowledge and expertise with us today. I would also like to thank Dr. Biswaranjan Jena sir and Dr. Partho Chaudhary sir for their insightful case presentations. Your contribution has undoubtedly expanded our understanding pertaining to the cases discussed today. I would also like to thank our esteemed audience for their time, continued love and support for the No Thrombosis program. On behalf of Emcure, I extend my heartfelt thanks to everyone from sales, marketing, and medical team at Emcure who have contributed to this program success. So thank you all once again for attending and encouraging us. Good night and good time ahead. Thank you.
Good night. Night,
Thank
Doctor.
you.
Night,
Thank
Sharma.
you. Thank you.
Thank
Good
you.
night.
Thank you.
Thank
Thank
you.
you.